So I am so thrilled to be here with everybody today talking about contrast enhanced mammography. It's a topic that I find incredibly exciting for our field, and hopefully all of you will too. I know there have been a lot of questions about it. It's kind of becoming a hot topic. People are implementing it. So feel free after the lecture is over, if we don't have enough time for questions, to reach out to me. I'm happy to answer anything. So let's get started. These are my disclosures. So this is what we're going to be talking about today. We'll start with the basics, move on to some of the challenges of contrast enhanced mammography. As we know, there's always some difficulty when you're starting something new. We'll talk about how people are using it in clinical practice, and then we'll move on to where it's headed in the future and some other kind of key ideas to mention. So we're going to start by talking about the basics. The wonderful thing about contrast enhanced mammography, and I should start by saying, you'll notice at the top of the slide, it says CEM, contrast enhanced mammography. Some people use the word contrast enhanced spectral mammography, or CESM, or contrast enhanced digital mammography, or CEDM. These are all the same thing. So I use CEM, so you'll see that throughout the talk. So the wonderful thing about contrast enhanced mammography is that it's just an adaptation of what we already know, which is conventional 2D mammography, which are the standard 4 views. But there are two key differences with a contrast mammogram. The first difference is that the images are acquired entirely after the injection of iodinated contrast. So a patient comes into the department, they have an IV line placed, which is a difference that the patient notes. Through the IV line, they have the iodinated contrast administered. 2 minutes from the start of the injection, they have what they perceive to be their normal mammogram. But this is where the second difference comes into play. This mammogram is actually performed using a dual energy technique. And so what does this mean? Well, for every imaging position, every time the breast is compressed in the CC or the MLO view, the unit is actually acquiring 2 pictures. The first picture is a low energy image, which looks just like a conventional 2D mammogram. You can see it here. Studies have actually shown that it's really similar, no different, non-inferior to a conventional 2D mammogram, which is great. You'll notice on the low energy image that there's already contrast in the breast, but you cannot see it on this 2D image, on the low energy image. And that's because this low energy image is performed below the kh of iodine, so it doesn't capture any of that iodine that's in the breast. The second image that's acquired is a high energy image. You'll notice it's blued out on my screen, and that's because it's non-interpretable. This high energy image is performed above the kh of iodine, so it captures all of that contrast material that's in the breast, but we don't ever see this picture. The unit automatically post-processes the low energy and the high energy images together to create something called a recombine image. And this image is similar to a subtraction image on MRI, where it really just highlights, it shows really well those areas of contrast enhancement. The low energy image and the recombined images are what we see as radiologists. Those are the images that get to our workstation, get sent to our workstation for imaging review. So what's excellent about contrast enhanced mammography is that we get to combine what we know, which is information on morphology and density, and we get to combine that with information on enhancement, and we don't need an MRI to do it. It's all performed at the same time. This imaging modality, contrast enhanced mammography, was actually approved over a decade ago at this point. It was approved for use in the diagnostic setting in 2011. It's only really increased throughout the country in the past few years. So let me show you an example of a contrast mammogram. This was a 55-year-old woman who had a mass on her screening, and she was recalled, and she had a diagnostic contrast enhanced mammo. These are her low energy images. Again, they look just like a 2D mammogram. Remember that the iodinated contrast has already been administered. There is already contrast within the breast. We just don't see it. So these are the low energy images, and you can see that there's a mass in the right breast. Can't really appreciate its margins that well. But then look at the recombined images. These are the images that show the enhancement, and you can see that there's definitely a mass here. You can see the margins of the mass. You can see how the mass is taking up that contrast. It's heterogeneous, necrotic in the center. And what you'll also notice is that there's no enhancement throughout the remaining aspect of that breast. So not only does it help us better classify what we're seeing, better understand it or characterize it, I should say, it also helps us exclude cancer in other portions of the breast. This is really great. This was a triple negative breast cancer. So this is how a contrast mammogram is acquired. So again, we start with an injection. IV line goes in the arm. We inject iodinated contrast material at a dose of 1.5 cc's per kilogram and at a rate of 3 cc's per second through a power injector. 2 minutes from the start of the injection, we start acquiring the standard for images of a mammogram. You'll see here each imaging set, so the low energy and the high energy image are considered an imaging set. Each of these is actually acquired 1 minute apart, such that the total exam takes roughly 5 to 6 minutes. If you're going to perform additional images, which sometimes I do, for example, I acquire 90-degree laterals for my diagnostic exams, those happen after the standard 4 views, and they have to happen within 10 minutes because we want to make sure that whatever contrast is in the breast, we can see it and it hasn't washed out. What's important to remember after the images are acquired, they get sent to our workstation, as I mentioned before, is that a contrast mammogram includes interpretation of both the low energy and the recombined images. They are both a part of it. So even if you see a suspicious abnormality on the low energy images, right, calcifications, and there's no enhancement, that is still considered a positive contrast enhanced mammogram. And there was actually a meta-analysis that was done that looked at data on contrast enhanced mammo and found that when both the low energy and the recombined images are included in the interpretation, the sensitivity is 95% and the specificity is 81%, which is fairly high. So it's really important to remember that both are included in your interpretation. Let's get into a little bit more about the difference between contrast enhanced mammography versus conventional mammo. There are some obvious benefits. To start, we can see cancers that would otherwise be obscured by glandular tissue on a mammogram. Let me show you an example or another example of this. This was a patient who had an asymmetry in the central portion of her left breast. You can see it's marked here by the circle. She came back for a diagnostic contrast mammogram. These are the low energy images, again, look just like a 2D, and you can see the mass there in the central aspect of the breast. The question is it a mass? Is it an asymmetry? On the low energy images, it really looks like a discrete finding. When we do the recombined images, we can see that there is definitely an abnormality there. This is a true finding. And we can also see that it's limited to that portion of the breast, and there are no other suspicious areas of enhancement throughout the remaining aspect of that breast. So again, helps us characterize a lesion and also improves our understanding of if there are other abnormalities throughout the remaining aspect of that breast or the contralateral breast. Studies are consistent. I'm not even going to show you one specific study on this, but the studies are consistent in that contrast enhanced mammography performs better than mammo for all performance metrics. And this isn't surprising because it's kind of like CAD, where it's just taking the information that we already have and providing more information. So we still have our conventional 2D images. We're just providing more information, which is the enhancement to help us identify more cancers and to help us exclude things that are just superimposed breast tissue. Another nice characteristic of this exam is that it can be performed at the same time as the diagnostic appointment. So you'll see, I already mentioned that if I have an abnormality that I identify on screening, I can bring the patient back and do a diagnostic contrast enhanced mammogram right then. I can better evaluate the finding, and I can actually use it as a staging exam. I can see if there's, I can see the full extent. I can see if there are other areas to worry about. And I could do it all at the time of the diagnostic appointment. I can show the patient the imaging findings. It's also, when compared to mammography, it's a timed exam and it's relatively fast. So we looked, our group looked at how long it actually takes to do a contrast mammogram, how it compares to diagnostic mammography. You'll see the DM is for diagnostic mammography. So we can figure out how much time we need to schedule or allot for this exam. So we compared these two. We also compared it to CT and MR, but I'm not going to focus on those. And we looked at different elements of the exam. We looked at EST, which is getting the equipment set up, PST, which is getting the patient set up, ET is exam time, and PT is the post-exam time. And what you see when you look at all these times taken together is that the contrast mammogram was roughly 30 minutes longer than a diagnostic exam. But when we broke that down, we actually found that the reason for the increase in length is because of that equipment setup time and patient setup time. And that the actual time for the exam, because it's a timed exam, was actually exceptionally similar. So what that told us is that, as you would expect, if we use the mammo room to put in the IV line and to talk to the patient ahead of time, it's going to extend the time of the contrast-enhanced mammo exam. What's better to do is to actually be able to do all of those preparatory steps in another room so that you're only using the mammo room for the time of the actual exam, which would be similar to a diagnostic exam. Another benefit is that you don't need a whole new machine or unit. It's not like MRI where you have to get the whole room outfitted for this specific modality. This is just if you have a mammo unit that's capable of being upgraded to allow for dual energy, you take the machine out of use for about a day or two. You have some software, firmware upgrade. You have to add in a new filter to allow for the high energy images. This is a picture of a copper filter. Also, titanium filters can be used, but this is really a simple thing to allow you to get this added information. Last thing I'm going to mention about radiation dose. So radiation dose is really a tough topic because we all try to compare radiation dose across modalities, across vendors, and it's very difficult to do because all of the vendors acquire images in a different way. And so it's very hard to compare one to another to say there's more or there's less. So what we did to get a sense for the actual radiation dose of contrast mammo is we took about 40 plus patients in our practice who had imaging on all of the different vendors that we have, and they had all different types of images, 2D plus DBT, and we compared the radiation dose. We calibrated all of it and compared the radiation dose across all of these exam types. And we stratified our results by breast tissue thickness. And what we found is that one of the exams that we perform all the time, which was a 2D plus a DBT for screening, we found that that was the highest radiation dose across breast tissue thicknesses. That's that blue arrow, still well within the range. So I don't want to suggest that this is a too high of a dose, but just this is what it was. A second vendor, which was these were the 2D images only, had the lowest radiation dose across breast tissue thicknesses. And this is where contrast mammo fell. So contrast mammo was actually the dose of one of these exams, which include low energy and high energy images, was actually similar to, was within the range of what we were providing to patients on a daily basis. So from my perspective, the take home for radiation dose is not that it's higher or lower than a different exam, but that it's well within the range of what we're doing for women every day, but we get this added information on enhancement, which we are not getting from our tests that only provide morphologic and density information. So let's talk about contrast enhanced mammo compared to MRI. Well, the studies have shown a similar accuracy of contrast mammo to MR. What this means really, it's a measure of how well contrast mammo accuracy is a measure of how well it finds cancer and how well it doesn't find non-cancer. So let's look at that. Sensitivity is ability to find cancer. And these are two meta-analyses performed in 2020 and 2022 with a different number of included studies. And they found that the first study found that the sensitivity for contrast mammo and MRI was the same, 97%. And the second one, more recent one, found that there was a difference in sensitivity. Contrast enhanced mammo had a sensitivity of 91%, MRI had a sensitivity of 97%, which was a little bit different and actually not unexpected, given that MRI is a cross-sectional imaging exam. We're getting much more information than we can on contrast enhanced mammo, which is a 2D planar exam. But when we look at the specificity, we see that the specificity is actually higher for contrast enhanced mammo as compared to MRI. And this, again, really the take-home message that I would say a majority of us leave when looking at all of the individual studies and at these meta-analyses is that MRI does do a little bit of a better job at finding individual breast cancers and by really a few extra, but it has contrast enhanced mammo has a much better specificity. So that overall the diagnostic accuracy of these two exams is fairly comparable. We'll get into the specific clinical how we're using it in clinical practice and how the data compares. Let's look at an example of a contrast-enhanced mammogram compared to MRI. So this is a low-energy image from a contrast mammo. We see a mass. These are the recombined images where we see a mass, but we can also see enhancement extending towards the nipple. And so let me show you, this is the MRI exam, which shows the exact same findings. And I would say for people that are new to contrast mammo, whenever you look at the recombined images, often enough, if you were to then perform an MRI, the images are almost identical. Identical is maybe a strong. They're very similar. And so how you would describe the imaging finding on the recombined images is similar to how you would describe it on an MRI. Contrast-enhanced mammography is also more affordable than MRI. We bill it as a diagnostic mammogram plus contrast. There's no formal code for it yet. It's also more accessible. As I mentioned, it's just an add-on to a mammography unit that can be upgraded. It allows for real-time interpretation, as I also mentioned. And so often enough, MRI is read offline. We read them when the patients are not here. For contrast-enhanced mammography, we can read them while the patient is sitting in our department. The number of times that I've done these exams and have shown the patients the images, have shown them when they're totally negative in a patient who has dense breast tissue is really comforting to these women to know, no, they can believe these results. Or similarly, in a patient where the contrast mammo is done for staging, I can say, no, don't worry. This area is isolated to this one small thing. You're good. The rest of your breasts are just fine. So this imaging modality allows us to maintain that communication with our patients, especially in this time where I think that communication and connection is important. Patients also prefer contrast-enhanced mammo. This was a study that we recently published. These are women who have a history of breast cancer, and we asked them, if both MRI and contrast mammo have an equal chance of finding your breast cancer, which would you prefer? And you can see that a far majority, 73%, hopefully like my annotations, actually would prefer CEM. Only 10% preferred MRI. Another nice thing is that we don't have to do an MRI biopsy. So for anybody considering CEM, I would highly recommend that you get CEM biopsy. I have not done it myself, but I've seen them and they are awesome. CEM biopsy is just like a stereo biopsy. The patient experience is very similar, and at least what I have perceived is so much better than what women are going through for these MRI biopsies. So it allows us to divert patients from MRI biopsy to CEM biopsy, and that's, I think, an absolute game changer for this imaging modality. We're going to move on to talking about challenges of CEM. As I mentioned, whenever we always have to talk about the challenges. There's always something that we need to discuss. And the main challenge of contrast-enhanced mammo really relates to contrast administration, as you would expect. So there's a real risk of contrast-related events. This includes what we used to call contrast-induced nephropathy, and now it's called contrast-associated or contrast-induced acute kidney injury. And it also includes extravasation of the contrast material in the arm after it's administered through the IV line. Contrast-associated acute kidney injury or contrast-induced nephropathy is not really, it's not really a thing anymore. Or I should say, people are questioning whether it's really a thing anymore. And so some institutions are actually not even evaluating for underlying risk factors for contrast, for this contrast complication. That being said, the ACR contrast manual still treats it as an entity to be mindful of. And so you should talk to your individual institution to see how they navigate this. Do they test people's renal function before administering contrast, or you can always refer to the ACR contrast manual for how to navigate this. There's also a challenge of contrast administration on workflow. Again, we have to place an IV line. We have to screen patients to make sure they're not at increased risk for developing a contrast reaction. And so that can impact the workflow through the department. Another challenge of contrast are false positives. So similar to MRI, areas that are benign can take up the contrast material. That's a challenge. Contrast mammography, when we look at it at the moment, it's really just, is there contrast or is there no contrast? We don't have all of the information that we have with MRI, T2 signal and maybe even diffusion weighted sequences. And so there's the real possibility to just see abnormal enhancement and to say, oh, this is concerning for breast cancer, and we have to do something about it. So there are false positives. Let's look at an example of that. This was a 56-year-old woman who had a history of left breast cancer that was treated with wide excision alone, and she had new right breast calcification. So you can see there's the surgical bed on the left. I marked it. That was where the wide excision was done. And these are the new calcifications on the right. This is the image showing, highly pleomorphic linear branching calcifications, BI-RADS 5. So we were worried about these for sure. These are the recombined images that show that there's abnormal enhancement associated with the new calcifications. Not surprising because these were concerning. They look like cancer. But what you'll also notice is that there's mass enhancement in the surgical bed. And we saw this and we thought for sure this is going to be a recurrence. This patient didn't have radiation therapy. It was only wide excision. And so we thought this was going to be a recurrence. We ended up having an MRI because this was early on in our implementation. We can see the same thing on the right with those calcifications. We had enhancement, and we also saw mass enhancement in the surgical bed on the left. And it turned out that this was not recurrence because we did a biopsy, and we found that it was just post-treatment change in the area of fat necrosis. So this is an example of a false positive on contrast mammo and MRI. Another challenge of contrast mammo are false negatives. False negatives happen because you have to remember that a contrast mammogram is still just a mammogram, right? We're still limited by what you can get on the detector. So sometimes you can miss lesions that are in the deep chest wall or in the medial breast. We're certainly not imaging the axilla, but that's not really the goal. Another reason for a false negative has to do with BPE, which is background parenchymal enhancement. So we know from MRI that normal glandular tissue can take up contrast to varying degrees. Same thing happens on a contrast mammogram, and you can see the image all the way on the left is minimal background parenchymal enhancement, where there's almost no uptake of the contrast material, as compared with marked background parenchymal enhancement, which is quite a bit of contrast uptake. So we have the same 4 categories on contrast mammo as we do with MRI: minimal, mild, moderate, and marked. And you can imagine that when you have marked a lot of background parenchymal enhancement, it might be difficult to appreciate a solitary area of enhancement. And so this can be a reason for a false negative on contrast enhanced mammography. Another challenge of contrast mammo, and this is really more of an implementation challenge, has to do with recombined only findings. We know from the literature that even if you see an abnormality on recombined imaging only, even if it's only one view, you have to take these seriously. One of the studies that was put out by Kim and colleagues showed that foci non-mass enhancement and mass enhancement had positive predictive values of at least 6%, all the way up to 40%. So you have to address these if you see them. And why that's an implementation challenge is that what happens, what do you do in these circumstances? The first thing you do is you have to see if there's a low energy correlate, because then maybe you can do a stereo or tomosynthesis guided biopsy. Well, if you don't have that, you can do an ultrasound and see if you have a target for ultrasound guided core biopsy. But if you don't have that, then what do you do? So we used to send these patients to MRI to do an MRI biopsy. Now with contrast enhanced mammo biopsy, you can do that, but you have to know how you're going to navigate these findings once you implement contrast enhanced mammo, because it's a real thing. It'll come up and you have to address these things. At the very least, you would do a follow-up, which is not recommended. So this is like the whirlwind tour of contrast enhanced mammo. We're going to move on to CEM and clinical practice. Let's start here. So there are a variety of clinical indications for contrast enhanced mammo. These are all diagnostic indications, as you'll notice, because I mentioned it's only approved in the diagnostic setting. And the last one on this list is high-risk supplemental screening, and that's because there are new recommendations that are allowing us to do contrast enhanced mammo in this setting, but it is not FDA approved, or at least allowing us, I should say, recommending as an alternative to MRI, and I'll get into that. For this talk, we're going to focus on these first 3 indications: cancer staging, evaluate neoadjuvant chemotherapy response, and recall from screening. So this is the first case. Finally, some pictures. This is a 68-year-old woman who was recalled for right breast architectural distortion. I'm not going to show you the tomo images. You can see the distortion is here marked by the yellow arrow. When we do the recombined images, you can see that there is a discrete mass here. And so this contrast mammo allowed us to both characterize the finding and also delineate extent. And that's really one of the beautiful things about this imaging modality. It allows us to do both right at the time of the diagnostic exam. You can also do this after biopsy. So this was a grade 2 hormone receptor positive breast cancer. This is another case. This is a 68-year-old woman who was recalled again for right breast architectural distortion. This is the area of distortion. It was a very subtle finding, not even worth showing you the 2D images for this particular case. These were the recombined images that showed us for sure that there's an abnormality in this location, but it also showed us that there were other abnormalities located in both breasts. These were all malignant. So this is an example for sure for architectural distortion. It helps us say, is this area something to worry about or not? And is there additional disease in other parts of the breast? We had an MRI, again, because this was during the earlier parts of our implementation. And you can see that these findings showed up on the MRI as well, and they were all malignant. So again, this really just highlights how similar the images are that we see on those recombined images to our MRI images, which is really why the sensitivities of the exam is so similar. This is another exam, but we've talked about distortion so far. This is a mass. This is a 75-year-old woman who had a history of bilateral breast cancer and recalled for diagnostic CEM for this right breast mass. Now what I like about this case, we can all see the mass, it's marked by the yellow arrow. But what I liked about this case and why I'm showing it is because we know that once you have cancer treatment, it can distort the breast. It can be difficult to figure out what is just related to the surgery and what is new that we need to worry about and remove or treat. And so what the recombined images did for us is they just showed us where the cancer was. And all of those other areas of distortion related to the post-surgical changes just disappear. And this was a grade 3 hormone receptor positive cancer. This is another example of contrast mammo. This was DCIS. This is for calcifications. And calcifications are different than distortion mass, and we'll talk about that. This was a patient with DCIS. You can see it was already biopsied. That was the clip. These are the calcifications, linear branching, very, very suspicious, right? Not surprising this came back as DCIS. This person couldn't get an MRI for disease extent, so we did a contrast mammogram. And what you'll notice is that the recombined images show no enhancement. So this is an example, and the reason why I'm including it. This is an example still of a positive contrast mammo because it's showing those calcifications, even though it's positive, even though there's no enhancement here. And this is one of the challenge of contrast mammo for calcifications where some DCIS, low-grade invasive ductal cancers might not show enhancement. We have to act on it anyway. So when thinking about cancer staging for calcifications, we don't actually use the recombined images to help us determine whether to do something about the calcifications. It's really to see, is there enhancement separate or beyond the area of calcifications that might impact the overall treatment plan. So in summary, here are a few studies that I'm just pulling out from the literature. Sumkin and al. In 2019, they compared CEM to MRI for cancer staging, and they found that the sensitivities for the primary cancer site are 93% versus 91%. And if you were to look through the literature, you would see this over and over again, these sensitivities being very similar to each other. And they also found that both imaging modalities, CEM and MRI, overestimate the tumor size to a similar degree. And this overestimation is by a few millimeters. We are not talking about centimeters here. Lobes et al. More recently, we're looking at contrast-enhanced mammography and MRI, and it's their evaluation of ILC, which is invasive lobular cancer, and found that both of them overestimate ILC by around 2 millimeters, very similar. And then Lee and colleagues in 2021 I'm providing information not on how well they found the cancer, but on what the positive predictive value, which is really how well, when you see something on contrast mammo or MRI, is it likely to be cancer? And you'll see that the positive predictive value is much higher for CEM over MRI. And this, again, is kind of borne out over and over again, which is when you see an abnormality on contrast mammo, it is more likely to be breast cancer than when you see an abnormality on MRI. And this likely is because, again, it's a 2D, it's a planar projection. So if it becomes obvious enough for us to see it, then we should act on it to a greater extent than with MRI. And yeah, that's mainly what I have to say about that. So in general, though, the take-home point is that contrast-enhanced mammography can be used as an alternative to MRI. So forgetting, the data is there, and this is what you should remember. So now we're going to look at a different area, a different clinical indication, which is using contrast-enhanced mammography to evaluate for neoadjuvant chemotherapy. So this was a patient who had a grade 3 HER2-positive breast cancer and had a positive lymph node. You can see the cancer marked by the thicker arrow and the node marked by the longer, thinner arrow. And so this is an example where the contrast mammo was used to see how the patient responded to treatment. So these are the recombined images initially before treatment, which show you what you would expect, the cancer and the node. And this is what we see after treatment. So the images in yellow are the pre-treatment images, and the images with the white annotations are post-treatment. And so on our low energy images, we can see that it looks like there's improvement. But you probably remember from other talks on neoadjuvant therapy, where typically we categorize things as total response, no response, and a partial response, which has to be at least 30%. And so the question is, where does this fall in? Is this a partial response? Is this a total response? So we get our recombined images, which give us a much better sense as to how this patient has responded to the chemotherapeutic treatment. So there was a meta-analysis in 2023, so recent, that showed that the sensitivity for evaluating neoadjuvant chemotherapy treatment response was actually better for CEM over MRI. And it showed that the specificity was actually a little bit worse, 68% to MRI. But they're always kind of balancing. These two imaging exams are always kind of teetering, like one is a little bit better, one is a little bit worse. Bernardi and colleagues in 2022 showed that the CEM size measurements correlate highly with the size measurements on MRI, and studies show variable rates of over and underestimates for contrast mammo and MRI, but always very similar. So it's hard to say, do they overestimate it by a few millimeters? Do they underestimate it by a few millimeters? I don't know what the exact answer for this is because the data is kind of, like I said, very variable. But the take-home point is that these two imaging exams are very similar, and that we can use contrast-enhanced mammography as an alternative to MRI for neoadjuvant chemotherapy treatment response, especially for sure if you don't have MRI, for sure. So now we're going to look at recalls, which is an area that I really love using it for, especially for architectural distortion. So this was a really amazing case. A colleague of mine recalled this patient for exceptionally subtle distortion that was marked here by the yellow arrows on tomo, really subtle. We brought her back for contrast-enhanced mammo. Why do I like it? Well, if it's subtle distortion, right, we know that distortion is subjective sometimes, right? So somebody can think that there's something there, and I can look at it and say, I don't see it at all. And then there's another group, which is very obvious distortion. We all know that there's something going on. So for those subtle distortions, we always have this balance of, well, what do we do if our diagnostic imaging is negative? Then do we still go for a biopsy for the initially identified? There's so much question about what the next step should be. So the contrast mammogram helps us decide. It gives more information to help triage. Is this something to worry about or not? And then on the flip side, if it's one of those obvious areas of architectural distortion, it really helps for staging. So this is an example of subtle distortion. Is this real? Is it not real? We bring her back and look at that. These are the recombined images, which show a large area of segmental enhancement. And this was absolutely real. There's no question about it. This was an invasive lobular cancer. And we could tell that there was something to worry about in minutes, I should say. The exam takes minutes. So the next example is recall for calcifications. And I already mentioned that you're going to act on calcifications that are suspicious regardless of whether there's enhancement or not. So the presence or absence of enhancement is only helpful if it's larger than the area of calcifications and it would impact your management. This patient had a very large area of calcifications throughout the central upper part of her left breast. You can see these calcifications here, they're pleomorphic, right? These are coming out, they were biopsied, they're malignant. We do a recombined image, we see that there's associated enhancement. So like, what's the point of this? Well, it's helped us know that there's no enhancement in the lower part of the breast, right? We can see that the enhancement and at least the disease is isolated to this area of calcifications. And it's also given us information about the right breast. So when you consider evaluating or using contrast mammo for calcifications, it's really to say, how is this going to help me? I'm already worried about the calcifications. I have to look for something more. And if that additional information will help me, then it's worth doing. This is DCIS. This was a recall for a possible mass. So there was the possible mass. You can see it better in the upper outer left breast. You can see it better on the MLO view. When you do the recombined images, you can see that there's this very discrete mass. I mean, look at that. This is a woman who has dense breast tissue. Hard to differentiate anything, right? If there's a subtle mass located within the dense breast tissue. And then we do the recombined images and all of the normal breast tissue goes away. And we see the mass, we see the size of it, we see the extent of it, and we can look at the contralateral breast and say, okay, this is really what we're talking about, this one small area. So now let's look at the data for architectural distortion. Again, this is an area that I really love. Patel and colleagues published the first study on this in 2017, and they said that enhancement was associated with 29 of the 30 cancers. So there was one cancer in their study that was not clearly associated with enhancement, but that person had marked background parenchymal enhancement. So it's difficult to know if it really wasn't associated with enhancement or it just wasn't perceived to be associated with enhancement. In 2021, there was another study done on architectural distortion and said that if there was no enhancement, you do not have to worry about this thing. So between these two, the real take home is, if there is no enhancement in a patient who has no background parenchymal enhancement or very little background parenchymal enhancement, the likelihood that that is cancer is very, very low. Once somebody has a lot of background parenchymal enhancement where it can impact your perception, your identification of abnormal enhancement, you want to be a little bit more cautious. We're looking at calcifications. Most invasive breast cancers enhance, but there are some invasive or DCIS, invasive cancers or DCIS that may not enhance. This is similar to MRI. And so we want to evaluate calcifications with suspicious morphology regardless of enhancement. And I talked already a little bit about when to use contrast enhanced mammo for these cases. Next, we'll talk about masses. Masses that are associated with enhancement are more likely to be malignant. If you have a mass on a low energy exam and there's no associated enhancement, the negative predictive value is very high. And that's no different than if you see a mass on a 2D mammogram and you do an MRI and you see no enhancement. That's the likelihood that that is a cancer is essentially zero. I mean, there is no, it's the negative predictive value of an absence of enhancement for a mass is very, very, very high. So we talked about some of the clinical indications, how people are using it, some of the data. Now we're going to talk about where things are headed in the future. There are three main areas that we're talking about, which is breast cancer screening, using contrast mammo in the diagnostic setting just to formalize those indications a little bit, and then radiomics, which is AI and machine learning, and really, really neat stuff is happening. So we'll talk about breast cancer screening. This is a topic that I think most of us who use contrast mammo, most people who see talks on contrast mammo, this is the area that we're most excited about, especially for women who have dense breast tissue, who are at high risk. Maybe they don't qualify for an MRI. Can we do a better job at finding breast cancers for these women above what we're already able to do for tomosynthesis with tomosynthesis and ultrasound? So this is a patient who is high risk for breast cancer. She had a contrast mammo. This was a screening exam. You'll see the low energy images were negative. And then we do the recombined images and you can see a hormone receptor positive cancer in the right breast. And so this is kind of what we're talking about. We're talking about identifying cancers that we would otherwise miss on our conventional imaging. I mean, this is why we're excited about MRI. So the problem is that the data is not yet there where we can do contrast mammo for screening. certainly it has not been FDA approved for this indication. So let's talk about the data. We have retrospective studies, reader studies, and then there's CMIS, which is really, really excellent, that have already been, CMIS is happening now, but there are some retrospective and reader studies that are out. So Soren and colleagues in 2018 compared contrast-enhanced mammography, the full exam, low energy and recombined images, to the low energy alone, which is kind of a surrogate for mammography. And they found an additional 13 breast cancers per 1,000 women screened. 2019, the MSK group looked at their data for contrast mammo, and they found a cancer detection rate of 15 per 1,000 women screened, which is much higher than the standard cancer detection rates we typically talk about with mammo or with tomosynthesis, which is about 3 to 6 breast cancers per 1,000. There's also retrospective studies on women who have had a history of breast cancer, those that are above average risk, women who have dense breasts, history of lobular neoplasia, and they all say the same thing, which is that contrast mammo does a better job than conventional mammo. CMIS, though, is really going to be the trial that helps differentiate, should we be doing this? It's a prospective trial, it's a multi-center trial. What CMIS is doing, it's recruiting about 2,000 women. These women are getting both tomosynthesis and contrast mammo, and it's going to be able to see what the difference is in cancer detection and also what the difference is in false positives, because that impacts our view of whether this is a good screening test. And they'll track contrast reactions and so that we can really get an overall look at how this modality plays for women who have dense breast tissue, the good and the bad, and compare it and see if this is something we want to do. The results of that should be out in a few years. It's very exciting. Stay tuned. My group published a trial more recently that compared contrast-enhanced mammo to MRI for breast cancer screening. We had 132 CEM and MRI exams in an asymptomatic population of women. 132, that's a huge number. And we had 12 radiologists look at all of these exams. And we compared the performance metrics. And what we found, as expected, is that CEM performed a little bit worse than the full MRI protocol. You can see CEM sensitivity was 89%, whereas the full MRI was at 94%. But look at the sensitivity of 2D mammography, which was 75%, much lower. We found that the specificity of contrast mammo was higher than the full MRI protocol, which again is what we'd expect. Fewer false positives. When we see something on an MRI, on a contrast mammo, it's more likely to be breast cancer. And when we look at that metric of accuracy, which is AUC, to see what the balance is between cancer detection and not finding benign things, we see that actually the accuracy is very similar between both of these exams. And we confirmed that contrast-enhanced mammography is not inferior to breast MRI. And this was great. I mean, we looked at a lot of cases and we had a lot of people look at it. And so this helps perpetuate the idea, move forward the idea that these two exams are very, very similar overall. Unfortunately, again, as I mentioned before, we don't have enough data yet to really embrace this fully for breast cancer screening. Certainly the organizations that guide us have not done so. And so really where we're at for screening is the ACR has acknowledged that CEM has value, but that there's limited data. And so it's really only recommending it when MRI cannot be performed. I imagine this will change over time, but this is where we stand today. The NCCN, which is the National Comprehensive Cancer Network, has a similar approach. Really use contrast mammo for breast cancer screening when you can't perform an MRI. Same thing with USOBI, which is the European Society of Breast Imaging. So that's kind of where we're at. I imagine that things will change over time, as I mentioned. Another area for the future is we're going to look at how contrast mammo specifically applies to palpable lumps, pathologic nipple discharge, high-risk screening evaluation, and screening recalls. More studies to see how it compares to our standard of care. There's a great trial called the RACER trial, Rapid Access to Contrast-Enhanced Spectral Mammography in Women Recalled from Breast Cancer Screening. This trial is randomizing patients to standard of care which is mammography ultrasound, versus CEM. And they're going to look at what the different performance is in terms of cancer detection, follow-ups, biopsies, etc. Missed cancers. So that is going to be really the results of this trial are going to be really great to help us figure out, is contrast mammo better? Maybe it has a slightly better or better cancer detection rate, but maybe there are other challenges that we need to be mindful of. Lastly, for future directions, we're going to talk about radiomics. Radiomics are really looking at differentiating cancer subtypes, trying to figure out, can we use contrast mammo and the contrast that we see on these images to differentiate benign from malignant disease, and lastly, to evaluate axillary metastases. Overall, the wonderful thing is that CEM-guided core biopsy is now available. You can get it. It's amazing. I'll show you an example of how that's used. I know we're running out of time. So this was a patient who had a recombined only finding. Let me show you this. So this was a patient who had architectural distortion in the left breast, marked by that yellow arrow. And we did a biopsy, a tomosynthesis guided biopsy, and you'll see that our clip is actually not where the architectural distortion was. So we weren't sure what to do about this. Did we sample appropriately the distortion and the clip moved, or were we just off? And this can happen with tomosynthesis guided biopsy. I imagine everybody on the call, or at least many people on the call, have had this issue. So we did a contrast mammo to get more information. And we found that there was no enhancement in the area of distortion, which is great, but there was enhancement in the right breast. The enhancement here, marked by the pink color, was a fibroadenoma, a known fibroadenoma, but you'll see that there was actually an incidental enhancement in the outer central right breast, and this was a malignancy. So, but what are we going to do with this thing? We sent her to ultrasound. We couldn't find it. There was no associate correlate on the low energy exam. So we had to send this patient to MRI. But now with contrast enhanced mammo biopsy, we'll be able to do that. Another notable change is that there's now a lexicon for how to interpret the imaging findings, which obviously I've not gone into any information about how to interpret the images that we see. Mostly the lexicon is built around the low energy images being similar to mammography and the recombined images being similar to MRI. So the lexicon is really geared towards mammography and MRI characteristics. The main changes are that there's now no focus. The term focus is not included in the CEM lexicon. We don't have the characteristics of dark internal septations, clustered ring, and we've added a term called enhancing asymmetry, which is a finding that you see, an area of enhancement that you see only on one view. And so with that, this is the summary of the talk. So you can always learn more. There are some books available, websites, journal articles, and feel free to reach out with questions anytime.
Hello, my name is Olena Weaver. I am an associate professor of diagnostic radiology at MD Anderson Cancer Center in Houston, Texas. And I'm the breast imaging director of contrast enhanced mammography at my institution. I am happy and delighted to be a part of this course on contrast enhanced mammography. And contrast enhanced mammography, I believe, is a very valuable tool in breast imaging. It's an emerging tool, but already has a lot of very valuable applications. It's still being researched, but I think the future of this modality is very bright, and it will find its way and its role in our everyday life and everyday breast imaging practice. I'm glad to be working with Dr. Jordana Phillips. This course will be a part of this overall contrast enhanced mammography course, and I'll present you a case-based review. So I have no disclosures. I would like to point out that the cases I will present to you today are going to be a little unusual because the majority of the cases I will show you were done within a few research studies at my institution. And I thought that having these cases will help you put together contrast mammography and digital breast tomosynthesis side by side. DBT, or digital breast tomosynthesis, is not a part of contrast enhanced mammography. Contrast mammography is really a 2D exam, But we do them together just for research purposes. And by putting them together here, I thought that that could help you compare, correlate, and see if you find that DBT might play a role in your practice alongside the contrast enhanced mammography and how those findings correlate. And again, remember that contrast mammography on its own is a 2D exam, but there is a possibility to do DBT and contrast mammography under the same compression. But whenever you decide to do that, you would have to do DBT first. Of course, remember that it does add some radiation dose. And this is just an example of how it looks like. This is the same case, craniocaudal view of the right breast. On the left, it's a DBT slice, and you might recognize that in this particular slice, you see some findings in focus. So this is a low energy image, which is just like Dr. Phillips mentioned, is equivalent to our regular full field digital mammogram. And of course, it's a planar image, so you don't see these 8 edges as well as on the DBT slice. And on the right is our recombined image. And this is the image of a contrast distribution in the breast. And of course, you see immediately at a glance the extent of disease, all those multiple masses and non-mass enhancement, and how well it helps us delineate the extent of disease in this breast.
So to get oriented, all of our images are down here. As you would expect, those that have a number are a tomo sequence with multiple slices. These here are a still or composite image. So first, just to get your images hung correctly, if you like the side-by-side, you can click this 2 series and hang things according to your preference. So here's a bilateral CC view. And then to get rid of these images, just click this icon. From here, we have a lot of options in our Home tab. So we can window, we can invert, we can get rid of our identifiers, we can put arrows down, we can measure things, we can erase, and we can restore the images back to their original form with this button. The Markup tab has more detailed graphical annotation tools. Occasionally, some of the cases will have a flipped or inverted image. Just go up here to flip or rotate and click the rotate button or the invert button accordingly. Last, I'm going to show you how to do a tomo. So if you wanted to pull up a tomo here and scroll through it, just make sure that you go back to the home and have the pointer selected, which will allow you to scroll through the image.
Okay, so we will start with the first case. And the first case is just meant to give you some introduction, how the contrast enhanced mammography images can be viewed, how they work together, and how you can evaluate the background parenchymal enhancement. So this is a 51-year-old woman with no complaints. She presented for a screening mammogram. And here we see on the top craniocaudal low energy images. So they, again, they are equivalent to our full field digital mammography images, and they are read that way. So we are first looking at low energy images, just like your regular mammogram. First, you want to get a good idea of whether there are any suspicious findings on low energy images before you even proceed to recombine images. And how you set it up on your packs really depends on your preferences, on your vendor. The beautiful thing about CEM is that you can seamlessly really incorporate it into your current mammography hanging protocols. If you have DBT, for example, you probably have a set of keys or shortcuts that you are using, or you are using like a pad to scroll from low energy to DBT. The same way you can scroll from low energy to recombine images, and you will notice that the anatomy really perfectly overlaps. So let's say on the top, we have craniocaudal images. You can toggle to recombine images, and you can immediately see, for example, that these vessels, they perfectly match the vessels on low energy images. And that's how you know that you're exactly in the right place. So this is a scattered fibroglandular densities, maybe some would call it heterogeneously dense. But when you're looking at the recombined images, this is an example of our minimal background parenchymal enhancement. So this is a very uniformly dark, not really much of background enhancement. Maybe here a little bit in the lower breast, but really it's a part of the background enhancement. It doesn't look like any particular finding. Here you can see in the right axilla on the MLO view, a little enhancing lymph node. And if you look back at your low energy image, that's the lymph node we are talking about. Take a look at here. You can see some little artifacts. So this is a recombined image, craniocaudal image of the left breast. You see these lines. It's kind of alternating dark and light lines in the medial breast. That's a little bit of a motion artifact. And if you compare it to the right side, there's none of that. And there's definitely no underlying pathology on the lower energy image. As you can see, there are some vessels, but none of that wavy line. So that was motion. And the other artifact I wanted to point out, it's very subtle. You may see these vertical light and dark alternating lines, especially in the upper breast in this MLO view. This is a grid artifact, and it's possible to have a grid artifact only on recombined images and not on low energy images, because if you see the low energy image, there's nothing there. The good thing about this kind of artifacts, both the motion and the grid artifacts, that they are not really affecting your interpretation of the image. You can just ignore them. As soon as you know what they are, you can work with your vendor, you can try to optimize your images, but they are not really affecting your ability to detect cancers. So, and another thing is, if you notice those little tiny black dots, these are calcifications. That's how calcifications usually show up. So at some point, it will be important when we will be talking about artifacts, because sometimes you see little white dots on recombined images, and those are usually not calcifications. See, so notice that the artifact that's created by the calcifications is little black dots. So this was a normal case of breast with scattered fibroglandular densities and minimal and symmetric background parenchymal enhancement. This case is a 62-year-old woman who presented for the evaluation of left nipple discharge. She had it for years. It was clear for many years. But she did have one episode of bloody discharge, so that alarmed her, and she came to us. So you can see that she has a heterogeneously dense breasts. It's a pretty symmetric pattern. These are lower energy images, the equivalent of FFDM, full field digital mammography. And these are recombined images of contrast enhanced mammography. So again, you can go back and forth, and you can see how the anatomy overlaps and how some morphologic findings might be matching the recombined imaging findings. For example, this little mass of lymph nodes, you can see that there is an enhancement right there. Just to explain the whole story behind this, she did undergo bilateral ultrasound. We found either cyst or cystic duct dilatation within the left nipple and right under the left nipple, and maybe possibly underlying hypoechoic mass right next to it. because, of course, because her nipple discharge is a potentially concerning symptom. So we took it seriously and we were working it out. She happened to have breast MRI, and this is a post-contrast T1 MIP, maximal intensity projection image, which gives you an overview of the overall background parenchymal enhancement on MRI and the tissue pattern. And notice how similar it is to this pattern of contrast enhanced mammography. So this patchy appearance, which we would call probably at least moderate or maybe even marked background parenchymal enhancement. So on this right MLO is probably even marked. So marked to moderate background parenchymal enhancement. And just like breast density for mammography, background parenchymal enhancement can be limiting for contrast enhanced mammography. So the more prominent background parenchymal enhancement, the less likely it is that you will find little enhancing masses. So moderate to marked background enhancement in this case. So just like on contrast mammography, which did not really find any focal findings, but rather this moderate to marked background enhancement, the same we see with breast MRI. Nothing really focal, just a lot of background. On some individual sequences of MRI, so you see that she did have one single duct with some T1 non-contrast high signal in it. So it's either blood or maybe proteinaceous fluid right here. Nothing really concerning in that area, nothing focal on post-contrast subtracted T1 MRI image. And we do see that cystic T2 bright lesion within the left nipple. So basically, this is to show the correlation between contrast mammography and MRI, and that MRI wasn't really much more helpful in figuring out the patient's symptoms. So this is her cyst. We did end up doing an ultrasound-guided biopsy of that little possible subareolar mass, and it was a benign finding, no malignant cells, benign proliferative ductal lesion on the background of proteinaceous debris. So in this case, it was a true negative, a bit challenging CEM, of course, because of the background parenchymal enhancement. But one of the reasons for demonstrating this case is that MRI might not be helpful. Let's say you're stuck doing some CEM cases and you think that MRI might solve your issues. Not always does, or not even often does, because it might have just the same pattern and the same issues as contrast enhanced mammography. And here's an example of how you can use your contrast enhanced mammography, especially the lower energy part of it, in relation to the prior images. So let's say this is your baseline contrast enhanced mammography and you see some mass. It's an enhancing mass, but you just happen to have a previous mammogram available to you. And you see that that mass, even though you didn't know that it was enhancing before, but it was there. As soon as the morphologic underlying lesion is there, we can consider it benign and stable. So, and I will show you how I would approach this case with the left nipple discharge on PACS. And again, you might have your own display, but here we can see so on the top, there are bilateral craniocaudal low energy images of contrast enhanced mammography. On the bottom, bilateral medial lateral oblique low energy images of contrast enhanced mammography. You can work with your PACS and make sure that your low energy images and recombined images overlap. And you can see that in this case, it's moderate to marked background parenchymal enhancement. It's not as smooth as we saw in the first case. Definitely a lot of background happening. So you might notice a little something that might look like non-mass enhancement in the outer breast on the left. But then we did additional views and looked at the medial lateral oblique projections, and there is really nothing. We also did an ultrasound later, and we did not find anything in that region. So we concluded that this is just for background parenchymal enhancement. And this might be difficult in these cases. Again, just like with dense breast, when you are limited in terms of what you can see through the breast density, you can be limited what you can see through the marked background parenchymal enhancement. So this is a case where we did have DBT, digital breast tomosynthesis, and just like with low energy and recombined images, you can toggle with your DBT. So you can actually see exactly what's under your enhancing findings. So just like in this case, in the outer breast, we see it's the classic lymph nodes with fatty hyla. And if you bring back your recombined image, you will see that there is a little bit of enhancement there. And there is a mass on the lower energy images. In our packs, we have buttons we can toggle through. Remember, you can do basically any additional views except for magnification views with contrast. You can do spot compression contrast views. You can do lateral views. So in this case, we were trying to figure out what's going on behind that nipple and did not really see anything new or suspicious from her prior images. So this is an example when we did spot tomosynthesis on that case. And this is an MLO view. Notice how you do not really see the pectoralis very well on recombined images. You do see enhancing lymph nodes. But again, the beauty of it is that you can cross-correlate with the low energy images under the same compression. And this was a lateral image. So this was a basically negative study with moderate to marked background parenchymal enhancement, no pathology. The woman, we saw this lady for another year and she is still okay. So she did not develop any cancer. So we consider it's a true negative study. So the next case is a 72-year-old woman who presented for dense breast screening for one of our research protocols. So you can see, again, on top, there's a medial lateral oblique, low energy images, on the bottom, craniocaudal images. You can set it up again, however you want on your packs. What is important about this case is one of the pitfalls of which you would have to get used to when you are just starting your program is axillary enhancement artifact. So take a look. So we saw that it was a heterogeneously dense breast, probably mild background parenchymal enhancement. It's still a relatively uniform gray, slightly kind of speckled appearance. So I would call it mild. You see the dense calcification that we had on the right. So it's bright white. But on the recombined image, it's actually appears as a black dot. But what I wanted to point out is this enhancement. So you can see it on some manufacturers' equipment more than others, and definitely have to look at it and evaluate it because cancers can appear like that. But in this particular case, it's relatively symmetric. And what is important, so when you are evaluating your lower energy image, you don't see any parenchymal tissue there at all, any glandular tissue. And there's this triangular looking artifact with a bit of enhancement along the edge of the pectoralis muscle. We usually don't see that, but sometimes recombination to some software issues, it can create this artifact. So along the pectoralis muscle, you can see this bright line and this triangle. Just keep in mind that usually it's symmetric, and when you're looking at the low energy images, there's usually nothing there. And if you're in doubt, then you can do an ultrasound for the evaluation. In our case, we also had the benefit of digital breast tomosynthesis under the same compression, and just scrolling through the DBT images just nothing there at all. So in this case, this artifact was relatively easy to dismiss on those grounds. Sometimes it's not as easy, so you need to do additional images. And especially at the beginning, you may even end up doing some biopsies of that, but it happens. 72-year-old woman who was recalled from her screening mammogram. And there was a mass and microcalcifications. So at first, this is just bilateral, craniocaudal, and mediolateral oblique low energy images. Already here, you can see that there is a mass in the right inner breast. This is the recombined images of the same breast, and you can see a little different background pattern than what we've seen so far. It's a little tiny speckles, so this is still mild, rather symmetric background parenchymal enhancement. But take a look, so remember this is the mass on the right, and take a look on the recombined image. There is a very well circumscribed, round, dark, uniformly dark mass with a very thin and uniform rim of enhancement. So this is a classic sign of a benign cyst called Eclipse sign, and it's very pathognomonic for a cyst. This is a DBT slice showing a nicely circumscribed mass, and this is a kind of close-up of that Eclipse sign. Again, very thin, and the inside of that cyst, it's a very dark and uniform. To be representative of the Eclipse sign, it doesn't need to be a very thin and uniform, especially the inside of that rim enhancement. We did an ultrasound, and it's a simple cyst. But another issue with that mammogram was that the patient had microcalcifications in the outer breast, or central outer breast. This is a magnification view. So it was lower outer breast, and you can see that there are some suspicious microcalcifications. This is a magnification view again. But looking back at her recombined images, so on the right in the square, that's the area of those microcalcifications. Of course, we don't expect to see them well on these monitors and on the full field view. But even knowing that there are some suspicious microcalcifications, there is nothing really suspicious at all from the enhancement standpoint. So the enhancement is pretty uniform here. And the same in the lower breast. So the calcifications are here, and there's nothing focal or suspicious or different in that area on the recombined images. We ended up doing a stereotactic biopsy of that area of calcifications, and it was benign, so fibroadenomas associated with microcalcifications. So in this case, it was a true negative recombined image. However, as you probably remember from Dr. Phillips's lecture, we are taking the contrast enhanced mammography as a whole. So if there are suspicious findings on low energy images, if they are suspicious enough, we are taking that seriously, and we need to biopsy it even if there is no enhancement, at least when we're talking about calcifications. So the next case is a 50-year-old woman with dense breasts who presented for CEM screening. We can see her low energy images demonstrate really heterogeneously dense or even extremely dense breasts. And we can discern multiple little masses. It's one of those cases that the more you look, the more of those masses you find. And it has been this changing pattern over the years. Some masses appear, some disappear. Very difficult to look at these cases because it's really hard to tell which of the new masses may be of potential clinical significance. And this is her set of recombined images. So you can see multiple little kind of punched out looking oval and round masses with dark center, and some demonstrate a thin rim of enhancement just like this. But some of them have some thicker rim enhancement or enhancement surrounding the finding, and some are more than others. So in this case, You can also see little circumscribed masses with no internal dark center. So in this case, the multiplicity of these findings and the fact that we could see on the prior images that there were masses in this area and they actually fluctuated in size, so we can think that the bilaterality and the kind of more symmetric nature of it is more towards the benign nature of these findings, probably inflammatory cysts. But have to be careful with this. So we ended up doing an ultrasound. So on ultrasound, it's very hard to tell which of those multiple cysts that we saw on both sides would correspond to the ones that demonstrated that rim enhancement. So just because we had so many prior studies, we were pretty confident that this is nothing besides just the inflammatory fibrocystic changes. So we dismissed it as a benign finding. What I wanted to point out here is that depending on the reconstruction, subtraction algorithm, different vendors can have a little different appearances of the images. So if you are planning to do, let's say, a 6 months follow-up of your studies, that's something to keep in mind. So on the top, there is a vendor 1, and on the bottom, it's a vendor 2. So, and you can see that the difference is, and we know that this is a perimenopausal woman. So to some degree, this could be due to a different stage of her menstrual cycle. But even looking at the, let's say, this slightly thicker skin, slightly more of a breast-and-breast artifact, and just an overall little different appearance. So that was the purpose. Just keep in mind that they can look a little different. So in summary, this was just a benign bilateral fibrocystic changes. So this is a PACS approach. This is a woman with dense breasts and multiple bilateral masses. The masses are fluctuating in size and number over the years, which is consistent with the changing pattern of cysts. But every time the woman comes and a new mass appears, it might be challenging to easily dismiss it. So in this case, you see on top is low energy images for this woman with extremely dense or heterogeneously dense breasts and multiple masses. So when we're looking at the recombined images, we can immediately see some of those masses demonstrate the eclipse sign, and some of those eclipse signs are clearer than others, like this, for example, the left upper outer breast. On the other hand, we see a few of similar appearing kind of little fuzzy eclipse signs. For example, there is one on the right, there is one on the left inner breast. So when we start going through our images, in this case, we had the benefit of having digital breast tomosynthesis images. So you can actually toggle and see. So, for example, this mass, the largest mass in the central left breast on the craniocaudal view, has a nice underlying eclipse sign. So no questions there, benign, dismissing. This one is a little more questionable in the outer breast on the craniocaudal view. This is not a clean and thin eclipse sign. However, since this woman was coming to us for many years, we just had a benefit of comparing to the prior studies, and we saw that there were larger cysts before. So this is actually a decrease in size from her prior appearance. So this, we were pretty comfortable in this case that this was a fibrocystic change with probably some inflammatory change around it. So the same in here, this is left upper outer fibrocystic changes with a little bit of inflammatory enhancement around it. And again, the bilaterality of it and the fact that the cysts decreased in size made us comfortable. And we did an ultrasound and also confirmed that these were just cysts. This is a 62-year-old woman who presented to us for screening within one of our research protocols. And for her, this happened to be her baseline CEM and baseline DBT, digital breast tomosynthesis. She happened to have multiple prior mammograms, but none of them were done with DBT and none of them were done with CEM. This is her low energy mammogram. And right here, we can see that on CC, on the craniocaudal view, there is some asymmetry in the central breast. When we do our contrast enhanced mammography on the recombined images, there is definitely non-mass enhancement, at least non-mass enhancement at 12 o'clock on the left. It's pretty asymmetric. It's at least it's moderate conspicuity. It definitely jumps at you. So on the left, it's a lower energy image. In the middle, it's recombined image. On the right, it's a DBT image. And on a DBT, we definitely see some kind of architectural distortion there. So it looks pretty suspicious. However, looking back on her prior 2D mammograms, she always had some kind of asymmetry there. There is no prior DBT to compare the distortion part of it, but the asymmetry has been there for several years at least. But now we know that there is a distortion, there is enhancement, so we are definitely concerned about it. We went for an ultrasound, found this kind of mixed echogenicity, rather hyperechoic maybe, or slightly hypoechoic mass within distinct margins. We believe that this corresponded to our mammographic finding, and we ended up doing an ultrasound-guided biopsy of it. And then, as you can see, the clip is exactly in the area of concern. And it was minimal usual ductal hyperplasia, apocrine metaplasia, minimal fat necrosis. She did not report any history of trauma. The point is, it was stable on 2D images, but it was enhancing, so we ended up biopsying it. It was a false positive DBT and recombined images, false positive. You definitely will encounter cases like that. It's very hard to dismiss them on the first CM, but just know that false positives like that exist and are not infrequent. And just for you to notice, in the left breast, in the upper outer breast, there is a skin mass. It's one of those cutaneous hemangiomas, but a larger one. It has been stable on multiple prior images. So right here, you can see an enhancing mass right on the skin surface. So another example of an enhancing cutaneous mass. This was a case of a 70-year-old woman who had the right breast invasive lobular cancer and DCIS in 2016. She had segmental mastectomy, and since then she complains of progressive right nipple inversion. So this case actually demonstrates potential usefulness of CEM in women with a personal history of breast cancer, and in my personal opinion, might be one of the most useful applications of this modality because of the difficulties that we experience with mammography in this patient population, especially if patients have dense breasts and they're younger and they have scars of prior segmental mastectomies. So this is potentially a very useful modality for that application. And there have been some ongoing trials right now, like TOSIN trial, Dr. Berg from UPMC, to demonstrate the potential use of CEM in women with a personal history of breast cancer. So here's a case. This woman has dense breasts. This is her low energy images. And you can see that she has architectural distortion and the nipple inversion on the right. We do know that she had segmental mastectomy there because there are multiple clips, but we do also see that it's progressively kind of contracting, becomes more distorted, and the nipple keeps inverting more and more, and that bothers the patient. And we know that we are limited in terms of how well we can see through all that dense breast tissue and the scar tissue on the mammogram. This is her DBT. So if you look at the DBT slice, again, a very distorted, maybe even mass-like, like you can imagine a spiculated mass there. But also know that that could be just a presentation of an evolving scar with increasing the fibrosis. If we do an ultrasound, we again expect to see very mass-like, irregular appearance with spiculations. Very hard to tell anything. If there's small masses or some new findings developing on this background, it would be very hard to tell. But here are her recombined images of CEM And we see absolutely a clean, minimal background enhancement and nothing at all of concern in the area of that architectural distortion or of that scar. So there is no question that this is a negative study, that this is a post-surgical scar evolving, but nothing suspicious about it. So this is an example of a true negative CEM in the patient with dense breasts and post-surgical changes. The next case is a 76-year-old woman who came to us with a known left breast cancer. It was diagnosed at an outside facility, and they noticed an architectural distortion in the left breast. So they did a DBT-guided biopsy of the left breast, and we know that this is an invasive cancer with mixed ductal and lobular features, low grade, ER/PR positive, HER2 negative. So she comes to us for staging. This is her low energy images, and we see a large circumscribed mass in the left upper breast. Otherwise, it's a heterogeneously dense breast tissue, a little asymmetric, more on the right than on the left. And we already have a clip there. So this is for prior biopsy site. This is the cancer site. And this is what we are seeing on the recombined images. So this is a counterexample to the cases of thin rim enhancement of so-called Eclipse sign. This is not Eclipse sign. So this is brightly enhancing, irregular enhancing rim. So this is something completely different, and we have to take much more seriously. So first of all, contrary to Eclipse sign, it's not a clean, dark circle inside. There is some density in there. So there is some overlapping tissue, and plus the rim enhancement is a little too bright, and it's quite irregular. So this is the most irregular part, which is pointed out. So one important point, of course, is that we are comparing it to the prior images, especially the images that were taken before the biopsy, and we see that that mass was not there. So this on the right is her full-field digital mammogram from the outside facility pre-biopsy, and only 1 month later. So we see that this is something new, and it's probably not a part of her original presentation. And these are examples of contrast-enhanced spot compression views. So you can do additional views with contrast, just not MAG views, but spot compression views are possible. So, and again, we see that it's irregular. There's probably even a little enhancing mass if you manage to displace the hematoma, which is obviously it is. So this is a hematoma with the rim enhancement, which developed after the biopsy. But we are more interested in this little mass, which is right below it. So it's below it on the lateral spot compression recombined images, and it's medial on the craniocaudal spot compression recombined images. And I just noticed that there is still something within that. So it's not a clear-cut eclipse sign. So, and the inner part of that circle is not smooth, but it's rather kind of irregular. So definitely not an eclipse sign. So you have to take it seriously. These are, again, examples of ability to do DBT under the same compression. And these are DBT slices. And you can see that there is some architectural distortion still to the side or like right below that hematoma, very subtle, but discernible. And that exactly corresponds to those areas of enhancement that we saw before. We did an ultrasound and mostly just saw the large hematoma, but there was a little bit of area of decreased echogenicity, which was difficult to say whether it was sediment or it was really the original mass. This is her clip. And she went for segmental mastectomy, and it confirmed invasive mammary carcinoma, low grade, 1.7 centimeter in diameter. Another point of this case is take a look at what we see on the skin. So you see these tiny little masses, In this case, on the left, it's a recombined MLO image, and we just happen to be capturing that image right on the skin surface. So it's a little oval mass. This is a DBT slice, which shows that that mass is definitely on the skin. It is enhancing, and this is her recombined image, and it shows actually several of these. So you see it's oval, circumscribed, enhancing, and it has a little dark rim around it. That's the air trapped around it. That's a very nice sign that these are on the skin. And these are her DBT slices. Again, shows that these are little masses on the skin. And this is an example of how they look like on a patient. So cherry hemangiomas are very important to keep in mind. They are very common, and they can show on your recombined images as enhancing masses. So very good idea to start recognizing them and to get used to them, so you don't confuse them with a malignant mass. This was a 78-year-old woman. We do know that she has Lynch syndrome, and she presented for staging of a known left breast cancer. So my institution is a tertiary cancer center, so we see a lot of cancer staging. So a lot of the cases that I have already have known breast cancer. In this case, it was invasive lobular cancer, ER/PR negative, HER2 positive. And she also has a history of chronic lymphocytic leukemia, which is currently in remission. So this is her low energy images. A little prominent lymph nodes, especially on the left. That's her chronic CLL. Other than that, well, we see a clip in her known cancer right here. And these are the recombined images. So this is pretty much an ideal situation that we expect to see with recombined images of contrast mammography when we have a minimal background parenchymal enhancement and high conspicuity solitary mass in the left breast. So we do know that this is an invasive lobular cancer. What we do need to deal often with when we're doing contrast enhanced mammography is a little incidental findings. Like in this case on the right, you can see a little area of maybe focal enhancement, even though it's only on one view. It was not seen on the lateral medial recombined images. So you remember that you can do additional views with CEM. You can do lateral views. You can do spot compression views if you want. So in this particular case, there was nothing on the craniocaudal view. The area disappeared on the lateral view. There was nothing really on the tomosynthesis. So this is something that we dismissed as a background parenchymal enhancement. You will see that quite a lot if you do CEM, and that could be judgment call. In some cases, one view asymmetries do need to be addressed, and there is a percent of cancers in those. In this case, although we were pretty confident that there was nothing there, so we dismissed that as a BP. And on the left, so this is the ultrasound. An interesting point here is that on ultrasound, you see this rather irregular mass with microlobulated margins, little angular margins, pretty irregular. However, on CEM, it looks a bit more circumscribed. Not circumscribed, of course, but much more circumscribed than on the ultrasound images. So ultrasound image appearance, this is a DBT image. So if you compare the morphology, the DBT slice seems to be corresponding to the ultrasound the best in terms of the morphology of it. And CEM gives us this more circumscribed round appearance of this mass. Again, more circumscribed, I don't mean that these are circumscribed margins. They obviously are not, but it's more so than the DBT or ultrasound. So these are lower energy images. I compare it to lower energy images. Of course, on the lower energy, we don't see margins at all. So DBT on the top and low energy on the bottom, just to see that low energy images in this case do not give us much information on the margins. The woman went for a segmental mastectomy, and it was confirmed that it was invasive lobular carcinoma, grade 2. 1.5 centimeter maximal diameter. So this is a PACS presentation of the case with the known left invasive lobular cancer. These are 4 low energy images on the top craniocaudal, on the bottom medial oblique. So you see that the known cancer on the left presents as a focal asymmetry with a clip in place. And when we are doing the recombined images, so we see that high conspicuity, regular enhancing mass in the left upper outer breast, that's the known cancer. And I wanted to show you this, thinking about this little maybe enhancing one view asymmetry, questionable one view enhancing asymmetry in the right lower breast on medial oblique projection. This is a lower energy image. This is that possible one view asymmetry. We happen to have a DBT, and we also did a lateral image. So lateral image demonstrates something that's definitely basal with some overlapping background parenchymal enhancement. And this is her DBT. And again, just watch this area right here. It seems like it's just the overlapping tissues and nothing there. So that's what gave us confidence dismissing that area as an artifact in the background parenchymal enhancement. And she has a clip there on the right from a prior benign biopsy. The next case is a 52-year-old woman who presented to us for a consultation. She had a biopsy at an outside facility and she wanted second opinion. So this is her low energy images, heterogeneously dense breasts. And clip in place may be associated focal asymmetry, hard to tell. She also has a mammographic mass in the right breast, oval mass with obscured margins. And these are her recombined images. And we definitely see the clip on the left. We don't see much in terms of the enhancement, maybe slight on the MLO, although we do have to be careful. We know that this woman just recently had a biopsy, and recent post-biopsy changes can show us some enhancement. So this is her recent biopsy site. And really nothing on the right in the area of that mammographic mass. Maybe we can kind of make out some little brim enhancement of a eclipse sign, but not very definite. So when we did a slightly delayed lateral recombined image, you see that there's already some degree of enhancement in the area of her post-procedure change or post-biopsy. So now we can see that there is a finding. So originally, actually, the woman presented with a palpable mass in the breast, and when an ultrasound was done, there was a 1.2 centimeter irregular hypoechoic mass at 3 o'clock. She also had a right breast ultrasound, and we saw a cyst at 12 o'clock of the right breast, and we saw a circumscribed oval mass at 10 o'clock. So there has been some literature specifically from UPMC, and they described that if there is an oval mass with no enhancement, in all likelihood, this is something benign. And you can see that there's nothing really of that size to correspond to the 3 o'clock mass, really nothing enhancing in the area of cyst at 12 o'clock as expected. So because it's an oval mass, we would be pretty confident. It's so circumscribed and looks very benign on ultrasound and non-enhancing. So the chances are that this is just a benign fibroadenoma. It just so happened that this woman had prior ultrasound, so it was a stable benign fibroadenoma. So it's a really true negative contrast enhanced mammogram, specifically true negative recombined mammogram for benign mass. I wanted to also point out, you might notice in the left axilla on the MLO view, there is a linear, like a white line with little white dots around it. If you take a close look at the images that are available to you, And on the corresponding low energy images, there is not much of that at all, or nothing at all. So this turned out to be a splash artifact, but it wasn't really on the working surface of the paddle or of the plate, because we wiped it multiple times. So, and actually we saw it on all four corners on multiple images, so multiple projections. So be careful, it can be inside of the paddle. Sometimes you just need to reach out to the vendor if you see that persistently. But the point is that the calcifications, for example, don't show as white little dots. You see that there's calcifications right here, and we don't see them as white dots. Really, the recombined images of CEM don't usually have that good of a resolution to demonstrate such small findings. So if you have this dotted white appearance, it's possible that this is an artifact, specifically a contrast splash artifact. And if you just wipe the surfaces, you should be able to get rid of it. And if not, then you need to contact your vendor. And this is another case that shows incidental cutaneous hemangiomas. So there's one in the left upper outer breast on both MLO and CC view, or right here on the right lateral breast on the craniocaudal view. So basically, this case was meant to show that the cancers not always brightly enhanced. They're not always very conspicuous. You've seen a case of highly conspicuous mass of invasive lobular cancer. Invasive lobular cancers actually do not necessarily brightly enhance, but they can. But some cancers enhance very faintly. So just because it faintly enhances, you cannot dismiss it. So in this case, it was invasive mucinous, and mucinous cancers are known to have less of an enhancement on the recombined images. It was a low-grade mucinous cancer, 9 millimeter on pathology. Now we have a 43-year-old woman with breast implants who presents for right breast cancer staging. These are full-field digital mammograms. Because when we are doing a case with implants, we do implant-in views with just full-field digital mammography, and we do CEM only on implant-displaced views. So this is a FMTM of her breasts with the implant-in. So you can see that the breasts are dense, the implants are relatively large volume, so it's very hard to see anything on these views. These are her displaced views, and the displaced views are done in CEM. So, and these are low energy images of the CEM on the implant displaced views. Again, we don't see much. We see the known mass in the right breast with the clip in place. And these are the recombined images of that implant displaced portion of the study. And you see an example of a regularly rim-enhancing mass in the right breast. So again, so this is not by any means looking like an eclipse sign. So it's a very irregular, especially inside. So we don't have a nicely circumscribed dark spots. Instead, we would have this very irregular looking enhancement. In this case, we already know that there's a cancer. So this is just an example of a solitary enhancing mass. And in a breast like this, in a dense breast, it's very helpful because now we know that this is a real, truly solitary finding, and we don't have to worry about anything else. And this is her ultrasound showing an irregular mass in the perioral breast at 2 o'clock. I just wanted to show you how it compares to a breast MRI. This patient just happened to have a breast MRI also, and it's very similar in appearance. So again, MRI T1 post-contrast subtracted image demonstrated an irregular rim-enhancing mass. It was a T2 bright inside, so that's where it could be mucin, it could be a necrotic part of this, or it could be hematoma. And this is her MIP. So the MIP looks pretty similar to the MIP is a maximal intensity projection of T1 post-contrast images. And this is the appearance when they have subtracted sagittal views. And she went for a segmental mastectomy, and it was invasive ductal carcinoma with mucinous features, grade 2, ER/PR positive, HER2 negative. It also had some ductal carcinoma in situ, and invasive cancer was 1.8 centimeter in diameter, which is very similar to what we saw on both CEM and MRI. So basically, just wanted to emphasize the possibility of doing contrast-enhanced mammography on patients with implants. And also, you may notice on these images some very faint vertical lines, dark lines. So that's a grid artifact of recombined images. It's not really preventing us from making an adequate diagnosis. It doesn't make the study non-diagnostic, but it's visible. So if you know what it is, you can contact your vendors and work on that, or just work around it. This is a 66-year-old woman presented for dense breast screening. So just wanted to emphasize that screening is not yet among the approved indications for CEM. We have a research study here, although it is recommended as an alternative to screening breast MRI in those women who cannot have MRI for whatever reason. So extremely dense breasts, very lumpy looking tissue, and a lot of calcifications throughout both breasts. So this woman has been coming for her screening for many, many years. As you can see, it's extremely limiting to look at the breasts like that with low energy or with the full field digital mammography. So multiple asymmetries. She has been recalled many times before, and you can see that she has scar markers on the right breast. She already had some excisional biopsies. So, and this is her recombined images. And immediately you can see that something is different here. Something that stands out is this enhancing mass at 11 o'clock of the left breast. She does have a mild background parenchymal enhancement, mostly along the edge of the breast, so-called breast and breast artifact, but it's pretty symmetric and easy to dismiss once you get used to it, but this is definitely something that stands out. And the interesting part is that when you look back on a low energy image, you kind of can see that there is something there, but when you have so many distractors, so many masses and asymmetries, plus when you're looking back at a couple years earlier, there was something there before, so it's very easy to dismiss it as something stable, and on DBT, which happened to have a DBT slice there, you already start seeing that this is actually a speculated mass. So this is the MLO view of the same breast. So very faint, maybe architectural distortion or asymmetry in the left upper breast. On DBT, wouldn't say that it's something definite. But again, when we're going back to our recombined images, it's very obvious that there is something there. So we did an ultrasound, and on ultrasound, we saw this mixed echogenicity, more even hyperechoic mass with indistinct margins. We were pretty sure that that's the correlate, and we ended up doing an ultrasound-guided biopsy of it. And on this image, you see that the clip is exactly in the area of concern, so we succeeded. And on pathology, it was an invasive ductal cancer with tubular features, low grade, with focal DCIS, ER/PR positive, HER2 negative. She opted for bilateral mastectomy, so which confirmed the cancer on the left. And she also had a right mastectomy, which did not really demonstrate any pathology there. This 48-year-old woman presented to us for right breast cancer staging. We do know that she has an invasive lobular carcinoma of the right breast, which was diagnosed at an outside facility. She has dense breasts, and she already came to us with 2 clips in the right breast. So looking at her low energy images, we can probably suspect a couple of at least focal asymmetries There are calcifications with those focal asymmetries. But when we do contrast mammography, we can see that the extent is actually quite a bit larger, especially in the craniocaudal, in the transverse plane. And when we have two sides of cancer, we obviously become much more suspicious about any additional finding in that breast. So we would not be dismissing these little lower conspicuity and smaller findings as a background parenchymal enhancement, especially when we have minimal background enhancement on the left. So it's the whole appearance is very asymmetric. In this case, we also had the benefit of having both contrast enhanced mammography and DBT. So what it shows here, we focused on the extent of disease in a transverse plane at this point. So let's say if this is the only extent of disease we're aware of, some women might actually still ask for breast conservation, and it might even be possible with some surgical approaches. However, when we suspect the extent of disease that much larger, at least in our institution, we are trying to confirm pathologically that this is, let's say, this most medial extent and the most lateral extent are part of this pathology. So we tried to find those most medial and most lateral lesions of the extent of disease. So on this image, so the most medial enhancing mass of this whole area of multiple masses and non-mass enhancement, when we are doing a DBT, it actually looks like there might be a little mass. On the right, there's a DBT slice at a different level, and it probably correlates to this most lateral enhancing mass on the craniocaudal view. So DBT can be helpful to actually find the underlying correlates. And then we went for an ultrasound. And when we go for ultrasound, we have a completely different approach in mind. We know that wherever we can see even small lesions, medial or lateral, are less likely to be fibrocystic changes and more likely to be a part of the whole extent of disease, because you wouldn't expect fibrocystic changes to actually enhance. So in this case, we saw this large conglomerate of masses at 12 o'clock, and that was a part of the previously biopsied pathology. These are all components of that conglomerate of masses. We saw another one at 1 o'clock, but also going more medial. So this is a very small, but looking closely at it, it's quite a regular mass, and knowing again, or recombined images, that we should be finding some extent of disease kind of lesions in that area, we decided to biopsy this one. And going actually towards the lateral aspect of the breast around 10 o'clock, we saw these little masses. And without knowing that there is something enhancing, it might be probably easier to dismiss it as a fibrocystic change, but we did know that there is something enhancing, so we do have to take it seriously, and we decided to biopsy this also with ultrasound guidance. So on the left, these are our new biopsy clips. These are the pre-existing, these are new biopsy clips. Obviously, right after the biopsy, the positioning is a little off, but it's still pretty close to the extent of disease in a transverse plane we expected to find. And these are our new clips on the lateral view, and we did know that the disease is mostly spread in the transverse view, so they are not very far from each other here. And again, pay attention to some little cutaneous cherry hemangioma, like in this case. So you already know that they are oval, they are enhancing, they have little dark rims of surrounding air. So those are benign cutaneous cherry hemangiomas. The patient ended up having a right mastectomy, and it was invasive lobular cancer, at least 10 centimeter in greater dimension. And she also had a left mastectomy, prophylactic mastectomy, and there was no cancer there, just lobular neoplasia, confirming our true negative CEM on the left. This is a 63-year-old woman of advanced breasts who presented for screening within one of our research protocols. So these are her low energy images, bilateral, dense breasts, as expected, a little suboptimal positioning on the craniocaudal view with the nipple not quite in profile. So just remember that the quality control for CEM is very similar to your regular mammography in terms of positioning. It's still the same requirements, requirements for the posterior nipple line, for the nipples in profile, for the concave pectoralis muscle contours on MLO views. So those are the same requirements, because really contrasting gas mammography is still a mammography. So low energy images, recombine images. Take a look at this area. So it's a focal, pretty low conspicuity, non-mass enhancement at 2 o'clock of the left breast. Among the cases which I presented, there is a case of artifactual axillary fat enhancement, which almost looks like this. So just remember that in this case, it's asymmetric. It has some densities on low energy images associated with it. And it's on 2 projections. So it's a focal non-mass enhancement, definitely has to be taken seriously. It's very asymmetric with the right side also. So the background of minimal or mild enhancement, and on this background, it is pretty noticeable, even though it's still low conspicuity, relatively low conspicuity. These are side by side, low energy and recombined images. So you see that there are some asymmetries on low energy images. So there is some morphologic underlying correlate. On DBT, there's a tiny little probable architectural distortion. So on the right, you can see a DBT slice. On the left, it's a recombined image. So if you happen to have, or if you decide to do for particular indications, DBT and CEM under the same compression, this is what you might see. So you can see that it's exactly the same area, little architectural distortion. But it was so a low conspicuity architectural distortion, and we only could see it on 1 projection really well. It was a questionable target for DBT-guided biopsy. So that's why we decided that we would prefer to have a contrast enhancement on board for our biopsy, because we just weren't quite sure we would be able to find that architectural distortion again on a DBT-guided biopsy after we have a focal compression. So, and this was a CEM. We did a CEM-guided biopsy. You see multiple images of the CEM-guided biopsy, is a step-by-step approach. Having a CEM-guided biopsy, if you have a CEM service, is extremely helpful, because if you don't have it, the only way to address the findings which are most pronounced or only seen on recombined images is to do an MRI and MRI-guided biopsy. So having a CEM-guided biopsy eliminates those extra steps and helps tremendously. So if at all possible, please try to acquire a CEM-guided biopsy device, which is really just a modified upright stereo unit. And the technique of a CEM-guided biopsy is very similar to your stereotactic, but you can use a DBT guidance with that process also. So here you see a SCOUT recombined image. These are 2 angled views of targeting. These are also recombined images. This is the pre-fire images and post-fire images. And at the end, we have our clip exactly in the area of concern on the original recombined images. And on pathology for this biopsy demonstrated invasive, moderately differentiated ductal carcinoma with invasive micropapillary pattern, grade 2. So again, just the lower conspicuity does not exclude the cancer. After that, she actually opted for mastectomy, and it was invasive cancer plus a DCIS. The residual was a DCIS grade 2, 20 millimeters. So the CEM actually did not see the 20 millimeter of disease, right? You notice it's probably 9 millimeter or so focal asymmetry. And it's not unusual because recombined images do not necessarily demonstrate DCIS very well. So in this case, there was a bit larger extent of disease due to DCIS. This is a case of a 74-year-old woman who presented to us for staging of right breast cancer. It was invasive ductal cancer grade 1 to 2, ERA positive, HER2 negative. These are her low energy images. You can see a mass, the speculated margins, and the clip. She has some implanted recording devices, cardiac monitoring devices in the left breast. These are her recombined images. Right away, you can see that there are some artifacts around those implantable devices. For whatever reason, mostly on the craniocaudal view. I'm not quite sure why but not so much on the lateral medial, but on the CC we see that, but it's obviously an artifact, so we can ignore that. And on the right, there is a enhancing mass with high conspicuity, so we know that that's the cancer. But also, we see this something that's either vessel or maybe linear non-mass enhancement on the left. This is this area circled on the low energy images. And this is a close-up. Actually, on magnification views, you might be able to see that there is actually ductal distribution calcifications in that area. And this is what that linear mass and non-mass enhancement corresponds to. On the right, as expected, there is a sonographic mass at 12 to 1 o'clock. And we already know that this is a cancer. But on the left, we ended up doing a stereotactic biopsy, and it was a DCIS, intermediate grade, solid and cribriform pattern. So again, to go back to, so these are calcifications, and these are her recombined images with linear non-mass enhancement. So this case demonstrates two different enhancement patterns of cancer. So highly conspicuous mass on the right, enhancing mass, and rather low conspicuity linear non-mass enhancement of DCIS. Just remember again that, especially with calcifications, the lack of enhancement should not prevent you from doing a biopsy if the appearance of those calcifications on low energy images is suspicious enough to biopsy. In this case, it just happened to be enhancing calcifications. This is an 84-year-old woman recalled from her screening mammogram for right breast microcalcifications. We just happen to have a research study for that. It's not necessarily an indication you would be routinely doing your CEM for, unless that's what you decide in your practice. But this was a research case. These are her low energy images, scattered fibroglandular densities. And this is the area of calcifications. When you take a closer look at the images available to you, you will be able to see them better. Here is the extent of the calcifications. And when we look at her recombined images, so on the background of minimal enhancements, especially take a look at the left breast. So minimal enhancement, not much going on there, and somewhat asymmetric enhancement on the right. So it's pretty inconspicuous, but comparing right and left, which is extremely important in CEM, just like in MRI, you can see that there is some asymmetry there. And it just happened to correspond to the area of microcalcifications. So this case actually demonstrates some struggles. And so whenever you start doing CEM, not every case is a straightforward high conspicuity mass. You start seeing stuff like this. And in this case, both the presence of suspicious microcalcifications and the asymmetric non-mass enhancement make you suspicious. So we need to biopsy it. And at first, we did just a stereotactic biopsy of microcalcifications. So it was at 10 o'clock, 1 centimeter from the nipple, and we got focal atypical ductal hyperplasia, only involving one terminal duct lobular unit, which is a very small focus of ADH, and some separate ducts with coarse calcifications and commiddle necrosis. This pathology was considered discordant. So we decided to use a CEM this time. So we went back to our images and we're looking at what is the most conspicuous or what is the most prominent or suspicious enhancement there, and decided that probably the craniocaudal view demonstrates as more targetable and more discrete areas of enhancement. So probably this medial breast and probably this lateral. So these are the areas which seemed like most prominent and most enhancing. So if we are to get cancer, the thinking was that it probably would be in these areas. So we went actually for a CEM-guided biopsy. And this is site 1, 2 to 3 o'clock, 3 centimeters from the nipple. It's on the top, it's a scout. This is a scout recombine image and the scout low energy image. So on low energy image, you see some calcifications, but on the recombine image, there is some non-mass enhancement with it. So at this point, you can either see it, okay, so enhancement kind of corresponds to that calcification, so I can use it as a target, or you can continue using your recombine images as the target, which we did in this case. It's pretty low conspicuity, and we knew that it would be. So on these paired images, we see a low conspicuity non-mass enhancement, which is still targetable on a CEM-guided biopsy. And here we actually got DCIS, intermediate nuclear grade, but now we have to think about the extent of disease and what's happening with the most lateral area. This was one of our earlier biopsies, and at that point, the thinking was that the contrast is washing out, so we only have 10-15 minutes to do the CEM-guided biopsy before the contrast washes out. Since then, that has been disputed, and the contrast seems to stay longer. But in this case, we did not attempt the second biopsy as a CEM biopsy because it was done during the same injection. So we did what we call CEM-directed stereotactic biopsy. So we saw where the calcifications are corresponding to that lateral area of enhancement, and we ended up doing a stereo biopsy of that and just got no atypia or malignancy. So that was a benign biopsy. And this is what we ended up having at the end in terms of our biopsy sites. So the most lateral clip is the original stereo biopsy of calcifications. You see there's no enhancement at all to correspond to that on CEM. This is a benign biopsy, but it does correspond to the area of non-mass enhancement. So we think that we biopsied that area well. And this is our DCIS, again, corresponds to the most conspicuous area of enhancement. So she went for segmental mastectomy, and it was actually extensive DCIS, 6 centimeter in greatest dimension. So the point of this case is that sometimes the findings can be subtle. Look for asymmetry. And in calcifications, when you have a large area of calcifications and you're just not sure which is the most representative area of calcifications and unsure about your concordance, CEM is something that can be potentially considered to find the most functionally suspicious area and use that as your biopsy target. This is a case of an 81-year-old woman who presented to our institution for left breast cancer staging. It was an invasive ductal cancer, grade 2, ER positive, HER2 equivocal. These are her low energy images, fatty or scattered fibroglandular densities. On the left, focal asymmetry or maybe a little mass with the clip. On the right, it's hard to see here, but you will have a benefit of magnifying that area. There is an area of regional microcalcifications. So here they are. However, looking at the contrast enhanced mammography, at the recombined images of the contrast enhanced mammography, we don't see any asymmetry at all on the right. So in the area of those calcifications, there is no enhancement at all, although we do see low to moderate conspicuity mass on the left, and that's the known cancer. When we do an ultrasound, we see, as expected, an irregular mass with a clip in place. So this is an MRI, breast MRI, and she happened to have an MRI also. And on the right, we see the left enhancing cancer on the maximal intensity projection image on the left. So this is her enhancing cancer. On the right, we see one duct with the T1 hyperintense material in it. So it's either blood or it's proteinaceous material, but it doesn't really enhance because this is actually a MIP of a post-contrast image. And this is a T1 shine through. You see that on pre-contrast image, it's also bright. Apart from that enhancing duct, the MRI didn't really show us any pathology either. So the point of me bringing up the MRI here is that neither CEM nor MRI showed any focal pathology in the area of concern, in the area of those mammographic microcalcifications. However, as Dr. Phillips pointed out, CEM is a combined exam, and the suspicious finding on low energy images are enough to do a biopsy and to do further workup, even if there is no enhancement on recombined images. So we did do a stereotactic guided biopsy of the right microcalcifications, and it was a DCIS intermediate grade. And on surgical pathology, she had a segmental mastectomy, which confirmed grade 2 DCIS of 5 millimeter in diameter. So it actually was not as big as the area of calcifications. But the point is that, especially with the calcifications, if the calcifications are suspicious enough, even if they don't enhance, they have to be biopsied. This 58-year-old woman presents for a right breast cancer staging. Her known cancer is invasive ductal, grade 1, ER/PR positive, HER2 negative. These are her low energy images. She has scattered fibroglandular densities. And on the right, we see a mass or focal asymmetry with a clip and a nipple inversion. On recombined images, we see an enhancing mass. But we also see this linear non-mass enhancement in the right outer breast. This is an incidental finding, and we can see it on both views, on both craniocaudal and MLO views. So we also happen to have a DBT on this patient. And you can see that this linear non-mass enhancement actually corresponds to a DBT finding, maybe a little focal asymmetry on DBT. Unless we saw something on recombined images, we probably would not think much about the DBT finding, but right now we can cross-correlate it. The good thing about having an option of doing a DBT, if you don't have a CEM-guided biopsy, you can try to attempt to do a DBT-guided biopsy if you have to. So this is for MLO view on the left, the recombined, on the right, a DBT view. And again, you can see that there might be a little mass or focal enhancement on DBT corresponding to our linear non-mass enhancement. So for retroareolar mass is obviously an irregular mass invading the nipple. And we decided to do a CEM-guided biopsy of our incidental non-mass enhancement in the right outer breast. So on the top, you see our combination scabbed approach. So this was a recombined image on the left. We did a DBT also under the same compression, and obviously on the right there is a low energy and we cannot see anything at all. So recombined images can be used as a target in this case. If needed, probably DBT can be used for this little finding underlying it. But in this case, we actually did see enhancement on both angled, paired, targeting recombined images. So it was okay to use for targeting. So we did the CEM-guided biopsy, and this is called pre-fire image. So we know that we are on target. So on this image, you can see the biopsy clip. Obviously, after the procedure, the positioning is a little bit off, but we were pretty confident that we got the correct area. And it was an invasive ductal cancer grade 1. So it was obviously a multicentric cancer in the right breast detected by CEM So the point of this one, so it was a presentation of a linear non-mass enhancement as an invasive cancer. This is a 42-year-old woman who presented to our institution with known right breast cancer for cancer staging. So her cancer is invasive ductal, grade 2, ER/PR positive, HER2 negative, and Ki-67 of 5%. She has very dense breasts, and we can see a clip in the right outer breast. Not much of a low energy finding, except for maybe one view asymmetry on the craniocaudal view. When we do CEM and recombine images of CEM, do demonstrate a mass in the right outer breast. So that's our known cancer. It's an enhancing mass, but she just happened to have at least moderate background parenchymal enhancement, moderate to marked. And the point of this case is basically that is a limitation that we have to deal with. So especially at the beginning, when you are just establishing your program, that can make you quite nervous, all the findings that you can find or that you can imagine on the case with marked to moderate background enhancement. So like in this case, is this something? So we did a spot compression view, which you can do with CEM. Didn't really see anything there persisting. There was nothing really on the MLO views, which I'm not showing here, but I am showing here some additional possible findings. On a left MLO, is that a real finding? Is the upper breast asymmetry a real finding? We did the lateral. It didn't really persist. It blended with the rest of the background enhancement. So we did do bilateral ultrasound and did not really find anything suspicious besides for known right cancer. So for known right cancer is a definite irregular mass with speculated margins. But other than that, just non-specific fibrocystic changes everywhere. And this was one of those cases that after just struggling a little bit, it was one of my earlier cases, dismissed it as a background enhancement. So just keep in mind that in some cases, there will be so much patchy background enhancement, you just have to accept, just like with MRI, it's a limitation. And on surgical pathology, on segmental mastectomy, it was invasive ductal cancer grade 2, 1.6 centimeter increased dimension. So she had her segmental mastectomy, she had her subradiation and hormonal therapy, and 1 year afterwards, she had a breast MRI. And of course, the background enhancement much decreased due to her anti-hormonal treatment, but we know that we haven't missed any cancer in the other breast or elsewhere on the right. So that was an illustration of a real life struggle with moderate to marked background parenchymal enhancement. This is a 77-year-old woman with a history of right breast DCIS, high-grade DCIS, diagnosed and treated in 2006. She underwent a segmental mastectomy and radiation. And since that treatment, she gradually developed more and more calcifications in the right breast. She had several stereotactic biopsies. And this is her low energy images. So you can see that she has some global asymmetry in the right outer breast. There are a couple of biopsy clips from the prior biopsies. That's what the arrows are pointing to. And this is the area of calcifications that continue to evolve or continue. So there's developing calcifications in that area, amorphous calcifications, but definitely more than before. So we can see that on the left it's 2022, on the right is 2019, and you can see that there's more density than there used to be, and the calcifications continue to increase. But it's a difficult case because we know that we already biopsied it twice, and the scars can evolve and they can get denser, and post-radiation changes can play into it, and fat necrosis calcifications can continue to develop. But we were concerned enough about them, and we did actually a CEM on her. This is her recombined images of CEM, and here's definitely we see that there is a problem. It's very asymmetric enhancement on the right, segmental distribution enhancement, probably even some masses, maybe at least in my mind, there's one mass in the subareolar breast. So if anything, I would be concentrating on this particular area to find my most functionally suspicious target for a biopsy. On the left, it's a mild background enhancement, pretty uniform throughout the breast, so we dismiss that as a background and concentrated on the right. This is her MRI. She just happened to have an MRI. We did not really order it to work up our CEM findings. She came with it from outside facility. And we see that it's a very similar presentation on this maximal intensity projection post-contrast image. It's the same shape and size of non-mass enhancement and maybe a mass here on the T1 post-contrast recombined image, and on sagittal image. It's the same kind of appearance. So when I went to do her ultrasound, I had this area in mind as my most likely area of potentially cancer. So if anything, I would like to biopsy that. So this is her ultrasound. She had a subareolar mass around 9 o'clock. So knowing that there is an enhancement, I call that a mass. It's actually in the radial view, you can see that it extends into the outer breast at 10 o'clock. So these were my two targets, 9 o'clock subareolar and 10 o'clock. I biopsied them both with ultrasound-guided biopsy, placed a ribbon clip into the subareolar and the coil clip into the 10 o'clock one. And there was also a suspicious lymph node in the level 1 axilla with diffuse cortical thickening. These are my post-procedure images, and you can see that the clips, so this is the ribbon clip and a subareolar mass, which does correspond to the enhancing mass on the recombined image. This is second clip. This is a coil clip. It also corresponds to the area of enhancement. And the same, but of course, these are lateral post biopsy images, so it's not quite the same positioning, but I was pretty satisfied with the location of the clips. And what it ended up being is a retroareolar mass at 9 o'clock, 5 centimeters from the nipple. It was invasive ductal cancer grade 2. The second mass at 10 o'clock, it was breast tissue with dense breast stromal fibrosis. And the lymph node was metastatic carcinoma. But definitely, I was thinking that the subareolar mass was the most enhancing one, and that's what showed us the cancer. So this is a kind of a CEM-directed ultrasound-guided biopsy. And she underwent total mastectomy. After a neoadjuvant chemotherapy, responded very well, and there was no residual cancer. Thank you very much for attending the course. I am very privileged to be a part of it, and I tried to present some cases to illustrate some of the points that were made by Dr. Phillips. I tried to demonstrate different presentations and different indications of CEM. I also tried to show that we don't expect that CEM will solve all our problems, but it actually can solve quite a few. This is still a work in progress. There's still a lot of research going on. There are some things we don't know yet about CEM. For example, how to follow up the probably benign findings, how it correlates with MRI or other things. So there's still a lot of research going on, and I'm sure very soon we will find more. But this is an extremely useful tool in our armamentarium. I think that if your practice has an ability to acquire contrast-enhanced mammography and hopefully contrast-enhanced mammography-guided biopsy, you will find it very useful. Thank you very much. And this is our wonderful research and clinical contrast-enhanced mammography team at MD Anderson. Thank you.